The Department of Medicine Grand Rounds. One announcement, a couple of comments before we have our speaker of the day. That promises to be an exciting presentation from the group from Medical Oncology. As you heard yesterday, we have a new dean. Dr. Toni Gamsel has accepted the position as Dean of the School of Medicine. So when you see her, congratulate her. But more important than that, she would very much appreciate if you offer your assistance in anything that she thinks or you think could be helpful to continue to move the school forward. So the second thing I wanted to mention is a couple of interesting things happen on this day in history, but they're all French. Now, don't ask me why. But back in 1794 was the death on this day of Antoine Laurent Lavoisier. And those of you in the pulmonary world know him. He was a French chemist, actually recognized as the father of modern chemistry. He was an aristocrat, and in fact, invested in a private company that helped the government collect taxes. So it turns out he was hired, and his company was hired to collect taxes. But with the private funds he actually generated, he developed a huge laboratory. And in 1778, he found that air consisted of two gases, or at least he felt that way, and he called them oxygen and nitrogen. He studied oxygen and combustion. He described the law of conservation of mass and devised a modern method of naming compounds. But the problem was when the French Revolution came, because people dismissed that and remembered him as a tax collector, he went to the guillotine. So focus on research, forget about taxes. The next thing, and more closer to us, in 1902 was the birth on this day of Dr. André Michel Lwoff, L-W-O-F-F. I'm not sure how to pronounce that. French biologist who studied bacteria. He looked at bacteria day in and day out and was interested in lysogeny, the idea that viruses can enter in bacteria. And he found that those can actually become part of the DNA of the bacteria, so they get promoted from generation to generation just by the division of the host. And he also observed that this didn't just happen, that bacteria didn't just secrete these viruses, that they had to be induced by external factors, and that led him to discover in the 1950s the inductive role of ultraviolet light and irradiation. And that led him and others to win the Nobel Prize of Physiology and Medicine in 1965. And with that, I'll leave you with interesting work in the area of head and neck cancer that will be introduced. The speaker will be introduced to you by Dr. Don Miller, the head of the Cancer Center. Thank you, Don.
Well, we should have a French speaker, but we don't. We do have a very good speaker. Many of you know we have an outstanding group of young hematology oncology faculty, and you're going to hear from one of them this morning. Rebecca Redman grew up in Wisconsin, went to undergraduate and medical school at University of Wisconsin, and then went to Chapel Hill to do her internship and residency, did her hematology oncology training at Duke, and we were very excited in late 2010 to recruit her here. And she has, I must say, far exceeded our expectations. Rebecca's done a great job initially working in the GI clinic, and when we had a need in head and neck, she stepped to the plate and has done a great job in becoming the head and neck oncologist. She's developed quite a number of clinical trials. She's the associate director of the clinical trials office in the Cancer Center and has just in general been a good citizen. This morning she's going to talk about one of the most exciting areas in hematology and oncology, and that is the epidemic of HPV-related head and neck cancer. Rebecca.
So thank you for having me here today. So I have no disclosures. So what I'm really going to talk about today is sex, drugs, and head and neck cancer. And that was actually going to be the original title of my talk, and then I sort of did an informal survey of my colleagues who told me that that might be a little bit too provocative for my first medicine grand rounds, and so I changed it to the more descriptive and bland HPV and head and neck cancer. So the drugs, of course, in head and neck cancer are tobacco and alcohol. In this picture, I actually took with my phone when I was rounding on 6 South, and it's a pack of cigarettes in a biohazard bag that was actually stuck inside a patient's chart, which I thought was quite funny. So U.S. smoking prevalence, this is from the CDC website, and this looks at smoking prevalence in adults starting in 1965. And then heading up to 2010. And the 1960s are right around when the U.S. Surgeon General released a report actually stating that smoking was hazardous to your health. And ever since then, it's been declining. Around now in the U.S., it's about 20% of adults that smoke on a regular basis. Here in Kentucky, that's still probably closer to 30%. So smoking is decreasing, and we typically think about smoking as one of the primary etiologies of head and neck cancer. Why is the incidence of oropharyngeal cancers increasing fairly precipitously? So when you look at this graph, you see oropharynx kind of is the dark blue, and it's a little hard to separate the lines, but it's the line that's going up. When you look at oral cavity, larynx, other pharyngeal cancers, the incidence is all coming down, which is what you would expect when you see decreased smoking, just as we see in lung cancer nowadays. But oropharyngeal cancer is heading steadily upward. This is taken from the SEER database, so this is looking at across the U.S., and then of course from 2010 to 2025, they're extrapolating and predicting the trajectory of incidence. So just a refresher on anatomy for those of us who this is not our favorite topic in medical school. When you look at head and neck cancers, they're actually divided for staging purposes into 6 main groups. And this is interesting because when you look at incidence and cancer incident rates reported by the NCI, they typically don't lump all head and neck cancers together. They're separated out. And so a lot of times you won't see head and neck cancer as one of those top leading categories. But when you combine these 6 subtypes, it actually comes up to a fairly significant amount of people. It's about 40,000 people in the U.S. that are diagnosed with head and neck cancer each year. So they're the oral cavity cancers, the pharyngeal cancers, which are then separated into nasopharynx, oropharynx, and hypopharynx. There's the larynx, the nasal cavity and sinuses, the salivary glands, and the thyroid. And each of those has its own individual TNM staging. So what about HPV and head and neck cancer? So the early 1980s are really the first reports of an association between head and neck cancer and HPV. And this is just when cervical cancer and HPV was starting to be evaluated as well. HPV and causality in cervical cancer was much more quickly accepted. When in epidemiology terms, association and causality are 2 very different things, and you can note an association, but whether a factor is causative of another event or whether it's just an association is a big deal, and there's a number of criteria that actually you have to satisfy to say something is causative. So that was accepted much earlier on in cervical cancer, but for quite some time went unnoticed, other than the association with head and neck cancer and HPV. But with this increasing incidence of oropharyngeal cancers in non-smokers, people started to look at this more and more. So oropharyngeal cancers now account for nearly 1/3 of all head and neck cancers. Previously, about 15 to 20 years ago, that was more on the order of about 15%. So it's about doubled in the past 15 to 20 years. And now upwards of 2/3 of these are actually HPV positive. So the smoking and alcohol-related oropharyngeal cancers now are the minority. So this is the HPV genome, and in particular HPV-16. So in cervical cancer, HPV-16, of course, is the dominant type that is attributed to cervical cancer, but probably accounts for 50 to 60%. In head and neck cancer, it's very different. That's upwards of 90% are related to HPV-16. So you can see there are a number of different genes, L1 and L2. E6 and E7 we'll talk a little bit about. Those are the ones that are constitutively expressed throughout the course of the malignancy. So both E6 and E7 are involved with tumor suppressors. So E6 associates with P53 via a few different proteins, promoting its degradation and preventing its activation. E7 binds the retinoblastoma tumor suppressor and thereby inactivates it. As a result of that, P16, which is actually a cyclin-dependent kinase, is overexpressed as a result of that. And that becomes convenient for us because we can use P16 staining on a tumor as somewhat of a surrogate for HPV positivity. And again, multiple studies have consistently demonstrated a significant correlation between HPV positivity by in situ hybridization and P16 immunohistochemistry. So how common is oral HPV? So this was a study, it was actually just published in JAMA last year, that was conducted within the U.S. National Health and Nutrition Examination Survey. So this was a study put together that was meant to be representative of the U.S. population, the civilian, non-institutionalized U.S. population. They selected 5,500 men and women aged 14 to 69 and asked them to participate. They were given surveys, asked a number of questions, and in addition, oral rinse samples were collected. So they were given 2 teaspoons of basically scope mouthwash, told to rinse in the mouth, gargle for about 30 seconds, and then spit it out. And they basically looked for the presence of HPV DNA by PCR and then did type-specific hybridization to type them out. Overall, you can see there's a pretty bimodal distribution of oral HPV. Overall, the HPV infection prevalence rate was 6.9%. It was 3 times more common in men. So when you look at men, it's closer to 10%, and you look at women, it's closer to 3 to 4%. So what are those types? And you can see, it might be a little bit hard to see, but the box in red is actually HPV-16, which is, of course, the one we were talking about earlier, being the culprit of most of the HPV-related cancers. And when you look at the prevalence of oral HPV-16, so again, this is just an oral rinse, and can you find HPV DNA in that oral rinse? It was about 1% of the population. So if you figure the U.S. population is somewhere around 320 million people, that's about a little over 3 million people that currently have an oral HPV infection, and that probably underestimates that sum. So what does that mean about your risk? So let's say you do have oral HPV. What is your risk of head and neck cancer? So this is actually a study that looked back quite a while. This was done in Norway, Finland, and Sweden, and they have a fabulous cancer registry in that it is nearly 100% complete. It's actually very closely monitored. They also have a high percentage of the population have donated serum samples to a serum bank for research purposes. So what they did is looked in their cancer registry through 1997. So this data was published in 2001. So they looked through the early 80s through 1997 and found all the consecutive patients diagnosed with a squamous cell cancer of the head and neck, and then linked that back to those serum samples that they had donated. And the serum samples, of course, had to be donated prior to their diagnosis. When you look at the odds ratio, and this is when you look at HPV seropositivity, so they look at those serum samples, who was seropositive for HPV-16 exposure. And then you look at the odds ratio for developing different types of head and neck cancer. You can see with lip cancers, it's fairly equivocal. There's not much change. Tongue cancer is about a 2 to 3-fold increase in tongue cancers in patients who were HPV-16 seropositive. Larynx and in general, all sites of head and neck cancer are about the same, but the oral pharynx you can see is 14 times increased risk of oral pharyngeal cancer if you're HPV-16 seropositive. And you can see the numbers are not huge. The confidence interval is quite wide, but nevertheless, that's fairly significant. So here's another study that's even a little bit more interesting. So these were patients diagnosed with head and neck cancer at Johns Hopkins between 2000 and 2006. So they basically took consecutive patients diagnosed. They had a total of 240, and then found an age and gender matched control, basically identified from patients seen for benign or non-malignant conditions at the ENT clinic. And you could argue those are probably not totally healthy controls. Those people were having some kind of complaint that brought them to an ENT physician. Could they be sort of in the earlier stages or undiagnosed cancer? It's hard to say. And again, they did oral rinses. And when you looked in the head and neck cancer patients, a third of those had HPV DNA detected in the oral rinses, compared to 3% of controls. Now, 3% is higher than what we would expect based on the previous study, which would say it should be somewhere around 1%. But when they adjusted out for all the different confounding risk factors, tobacco, alcohol, oral hygiene, race, sexual history, they actually came up with an adjusted odds ratio of 53. So saying that if somebody had oral HPV-16, they had a 50-time higher rate of getting a head and neck cancer. So how does that compare to tobacco and alcohol? We sort of have all accepted nowadays that smoking and drinking are related to head and neck cancer. And how do those odds ratios compare to oral HPV infection? So this was a study done in the mid-'80s in Atlanta, Los Angeles, San Francisco, and New Jersey. And they basically took all patients who were diagnosed with head and neck cancer during that time and sent them surveys. They actually got 75% response, which is pretty impressive. And then they found about 1,200 population-based controls. And when you tease out the data, you can see 20 to 39 years of smoking, and this is simply duration of smoking. This is not pack years, it's simply how long have you been smoking. 20 to 39 years for both men and women, a 2 to 3-fold increased risk of head and neck cancer. 40 plus years, you're looking at more like 3 to 5-fold risk, and the risk always seems to be higher in females. Interestingly, I put in here quit smoking, and that's anybody who's quit in the past 10 years. And it's interesting because even if you've only quit a year or two ago, your odds ratio goes down dramatically. And this is in keeping with what we're starting to see in lung cancer, that there really is a benefit to quitting. There's certainly still a risk a couple of years out, but once you get out to 10 years out from quitting smoking, your risk of a head and neck cancer actually goes down to that of the general population. So I think that's further information for us to use to tell our patients, look, it's really important that you do quit. Your risk does go down if you do quit. When you look at alcohol, so 15 to 29 alcoholic beverages per week, so 2 to 3 drinks a night, increases your risk about 3-fold. 30 or more, which is about 4 drinks or more, increases it more, about 9-fold. Interestingly, that's mostly beer and hard liquor. When you look at the wine data, wine doesn't seem to increase the risk of head and neck cancer quite as much unless you're drinking 4 or more glasses a night, which is about a bottle a night. So when you combine the two, though, is where it gets the most compelling. And so if you have somebody who has a 40-pack year smoking history, smokes 2 packs a day for 20 or more years, and drinks 30 alcoholic beverages per week, they have anywhere from a 37 to greater than 100-fold risk of head and neck cancer. But again, when you look at that compared to what we just talked about with HPV infection, and HPV infection, the relative risk is anywhere from 14 to 50 times. So it really is, oral HPV is being recognized more and more as a significant risk factor, rivaling smoking and alcohol as a risk factor for head and neck cancer. So Otis Brawley, who basically made a comment to the media saying this is one of the epidemics of the 21st century. This is a huge problem, and it is. And this is in reference to all HPV-associated malignancies. That holds true for anal cancer, which has also been increasing in incidence. The National Cancer Institute releases an annual report every year, and in January that's released. And there was quite a bit of press about HPV-related cancers after that, and most of the major news networks carried a story on it, a lot of the major newspapers. So is it really an epidemic? What's an epidemic? So this was the SEER database. There's 3 that have actually a residual tissue repository program. So a few years back, they started retrospectively requesting any kind of residual tissue that was left and banking it. And so this study went back and identified 271 formalin-fixed, paraffin-embedded oropharyngeal cancers. Now, again, these are from Hawaii, Iowa, and Los Angeles. So it's predominantly white and then Hawaiian patients. Your first question when you're going back as far as 1988 automatically is, well, of course you see less HPV DNA from 1988 because the samples are 20 years old. You're going to get DNA degradation. They're not going to be quite as good of samples. So, of course, they had very good positive controls. They took cervical cancer specimens, which virtually all of which are associated with HPV, and then had negative controls with gastric cancer. You can see the overall incidence of oral pharynx cancers in the yellow line is increasing. When you look at the gray line, though, that's the HPV-negative oropharyngeal cancers, which are decreasing along with smoking incidence. But the blue line is the HPV-positive oropharyngeal cancers. So from 1988 to 2004, it increased by 225%. So more than doubled in that short period of time. Similarly, when they looked at this tissue, they actually, by various different methods, tried to detect HPV in the samples. And so they did L1, looking at the L1 capsid protein and presence of that. They looked at HPV-16 viral load. They looked at E6 and E7 mRNA. They looked at in situ hybridization for HPV-16. And you can see in 1984 and 1989, the incidence of HPV-associated oropharyngeal cancer was somewhere on the order of 20% or so. When you get to the 2000 to 2004 range, that is closer to 60 to 80%, depending on the method looked at. So you can see it's pretty impressive that the majority of oropharyngeal cancers nowadays are HPV-related and not smoking-related. So when we see these patients in clinic, typically there's this period of, well, I don't smoke, I don't drink, I don't understand how I got this. And, there's usually a room full of people, and it becomes, well, it's related to this virus, and there's this, it's HPV, and there's this awkward pause, and then it's still kind of, well, how did I get this? Or oftentimes it's after we all leave the room, and then the nurse goes in and comes back out and says, they have some more questions. And so you go back in, and it's, I don't understand, how did I get this? Is my spouse at risk? So is my significant other, who I've been with for 40 years, are they at risk of getting an HPV cancer now? I had one young man ask me if he should be sharing a soda with his son, worried that he would be passing it on to his children. So what do we know about this in terms of what's out there? So HPV transmission, when you look at, this is a study that looked at 100 patients with newly diagnosed oropharyngeal cancer, and then of course found 200 age and gender matched controls. And the risk factors are as you would expect. So a high number of lifetime vaginal sex partners, in this study they actually used 26 as their cutoff, had a 3-fold higher incidence of oral HPV infection. More than 6 lifetime oral sex partners, again, about the same, a 3-fold increased risk. Of oral pharyngeal cancer, not of oral HPV infection, but a 3-fold increased risk of oral pharyngeal cancer. And if they actually had oral HPV-16 infection, they actually, again, here's the 14-fold increased risk of HPV-positive oral pharyngeal cancer. So that's how you probably get HPV, but the question becomes, can you get HPV from methods other than oral sex or vaginal sex? And kind of going with the question that gentleman asked me is can you get HPV from kissing or just passing saliva? And this was a study, again, going back to that original study that looked at a population in the U.S. National Health and Nutrition Examination Survey, where they had 5,500 men and women aged 14 to 69. Actually, about 10% of those surveyed said they had never had vaginal, anal, or oral sex. And despite that, HPV prevalence rate was 0.9%. And so there's always problems with surveys. Are people being truthful, forthcoming, et cetera? But this has been shown time and time again. There was actually a study done of 200 college-aged men in Maryland, and it was an anonymous survey. And a quarter reported never having oral sex, and of those, still 1.5 to 2% had evidence of HPV infection. And in fact, those with a higher number of open-mouth kissing partners is how they described it. If you had more than 5 recent kissing partners or more than 10 lifetime kissing partners, you had a significantly higher risk of oral HPV, even if you had never had oral sex. And so that's pretty provocative and raises some questions. And I think to date, we don't really know, to be honest, of how easily this is transmitted. But it's certainly out there. So what about the natural history of HPV in partners of patients infected? So when you look at studies, concordance rates of HPV types in long-term monogamous partners is generally less than 50%, and that probably speaks a lot to the role of the host in maintaining an HPV infection and immunity. Certain infections are cleared, certain infections are not. There was probably the best study was a Finnish study, which followed 330 women who were enrolled in their 3rd trimester, and then their significant others. They had oral scrapings taken at 0 months, 2 months, 6 months, 12 months, and then at 2 years. And those who had a persistent oral HPV infection that was noted at enrollment and again was still present 2 years later, their partner actually had a 10-fold higher risk of having that same persistent oral HPV infection. So there's something about the host immunity, but there's also something about the viral type, in that certain types are probably more likely to stick around. And so certainly having a partner who has an oral HPV infection and then is diagnosed with a head and neck cancer, in theory, would put someone at higher risk. However, what that absolute risk is, we honestly don't know. So what does head and neck cancer look like in the HPV positive population? It's different. It presents differently than the HPV negative population. So on average, patients are about 10 years younger. We know that the diagnosis of a head and neck cancer follows HPV infection by at least 10 years or more. Again, it tends to be primarily in the oral pharynx. They tend to present with very bulky cystic nodal disease. So unlike patients with HPV and negative cancer who come to attention because of their primary cancer, they're hoarse because of their larynx, they have a sore throat because of their huge base of tongue mass. Patients with head and neck cancer tend to present with very small primaries and then have very bulky nodal disease. So they may more often come to attention because of their bulky nodal disease, oftentimes asymptomatic from their primary. Similar to what we see in head and neck cancer in general, and also similar to what we see in the prevalence of oral HPV infection, men outnumber women 3-to-1 in terms of HPV-associated head and neck cancers. Under the microscope, they tend to be very poorly differentiated, and they tend to have a basaloid histology. So this is actually a CT of the neck of a patient with an HPV-related tumor, and you can see the lymph nodes that are involved are very cystic. They're oftentimes mistaken for a cyst, and so it's something to definitely keep an eye on. So what about prognosis? How do patients do compared to HPV-negative tumors? So this was actually a retrospective study. Oh, that's better. In stage 3 and 4 oropharyngeal cancer who were enrolled in a clinical trial comparing accelerated versus standard fractionation radiation. Both were given concurrently with chemotherapy. And regardless of the arm that they were actually randomized into, you can see that the HPV positive patients, whether you look at tumor HPV status by in situ hybridization or whether you look at P16 immunohistochemistry, consistently did better. Significantly better. When you look at the actual numbers, overall survival in the HPV negative population is somewhere around 50%. In the HPV positive population, that's closer to 80%. And those numbers are similar across the board. There have been things hypothesized that maybe HPV positive tumors are more sensitive to radiation. Somehow maybe that accounts for their better survival, particularly in the locally advanced setting. This study, again, looked at the SEER residual tissue repository. So these were patients treated with multiple different modalities of treatment. They looked at P16, again, as a marker of HPV positivity. And you can see, again, the P16 positive patients did better. This is a pretty diverse group of people, various stages, various treatment modalities. The P16 patients always did better. What about chemo? So when you look at how they do with chemotherapy, this is an induction chemotherapy study. So these patients got chemotherapy up front, and those who responded went on to get concurrent chemotherapy and radiation. And about half of the patients who were actually enrolled had tissue that was evaluable. And again, these are survival curves, but you can also look at response curves. And patients with HPV-associated head and neck cancers did better. They had better survival, they did better. So there's a suggestion that even with chemotherapy, perhaps they respond better. And in this study, about 50% were HPV positive. So what about surgery? We don't typically do surgery for oropharyngeal cancers. The buzzword in oropharyngeal cancers is organ preservation, right? So a base of tongue lesion, a tonsillar lesion. You try to let people keep the organs that they have. It's very difficult to remove the base of tongue without causing significant morbidity. So many of these patients get concurrent chemotherapy and radiation. So we don't have a lot of surgical data or surgery alone in these populations. This is actually a study done in Italy. And they did a retrospective study. There was 100 patients, 90 of whom they actually had follow-up on, with oropharyngeal cancer who were treated primarily with surgery for one reason or another, some of whom did get adjuvant radiation or chemotherapy. But again, the HPV positive, the blue line on top, did better. And again, you see that's by about 30 to 40%. The yellow and gray lines we're looking at mutated P53 versus wild type. Most of HPV negative tumors are P53 mutated, and that was not nearly as strong of an indicator of survival as was HPV status. So at the end of the day, survival in HPV positive head and neck cancer matched stage for stage is consistently better than HPV negative, regardless of the modality of treatment. And it's usually by more than 30% in terms of overall survival. So it's a pretty significant prognostic feature. So what about smoking? What about those patients, especially those patients here in Kentucky who might have an HPV-related tumor but also smoke? What does that mean for them? And this study looked at that. So again, this was that same retrospective study looking back at stage 3 and 4 oropharyngeal cancer patients who got different types of radiation but both given with chemotherapy, and they separated them into 3 groups. So you had your low-risk group, which was patients who had less than 10 pack years of smoking and were HPV positive. You had the intermediate risk, who had HPV positive tumors oftentimes, but were heavy smokers or had very advanced disease. They also could be HPV negative tumors with a less than 10% or less than 10 pack year smoking history. And then you have the high risk, who were, of course, the HPV negative tumors with a significant smoking history. And you can see when you see the survival curves over on the right, the low risk patients, so those who had minimal smoking history and were HPV positive, had excellent survival. At 5 years out, upwards of 85% were alive. When you look at the intermediate risk, those patients who maybe were smokers but also were HPV positive, it's somewhere in the middle, closer to 70%. And then the high risk, of course, is what we see with the HPV negative heavy smokers, where it's closer to 30 to 40%. So smoking really does kind of still continue to play a role even within the HPV positive population. So what about EGFR? People have looked at EGFR expression as another way to try to tease out prognosis. And this was a fairly small study. You can see overall they had about 30 patients, I think, or 40 patients. But they looked at EGFR expression. And you can see EGFR expression is, and this is a pretty hot topic now too, is quite a significant prognostic factor in some studies. The red and gray lines on top are actually low EGFR expression, and those patients did extremely well. Again, you're looking at an N of 20, but still. High EGFR expression is where HPV became a little bit more interesting. The yellow and the blue lines separate. The yellow is the high EGFR expression, the HPV-16 positive. Patients who were HPV-16 negative but had high EGFR expression did horribly, did very poorly, and in this study most were dead by 2 years. So when you look at it's evolving story. It's not just HPV positivity, but within the HPV positive population, what other things can we look at to gauge how a patient's going to do? And that makes a big difference when we look ahead to how can this change treatment? How does this change how we treat head and neck cancer? This has completely changed the demographics of head and neck cancer. The people we see come to the head and neck clinic, different risk factors, different demographics, younger patients. And again, the key is organ preservation, and that continues to be the case whether it's HPV positive or HPV negative. Right now, we don't have enough data, and there are a lot of studies ongoing, to alter treatment based solely upon HPV status. We know survival is excellent. However, the morbidity associated with treatment is quite significant. Most oropharyngeal cancers will get concurrent chemotherapy and radiation, but again, that's associated with significant toxicity. So now you have this population, increasing incidence of HPV positive tumors, younger patients, less comorbid conditions, who are going to survive for a very long time and are left with significant morbidity and long-term toxicities related to their treatment. So how does that change, or where are we going from here in terms of treating HPV positive tumors? And this is in general, how do we improve cancer treatment? So when you look at how we improve cancer treatment, you can separate it into two broad categories. So you have those cancers where you're really great at curing people, very good survival, and you focus on decreasing morbidity. How can we improve treatment? How can we decrease morbidity, decrease long-term toxicities? And then you have looking at improving survival, and that's typically an additive approach. You add drug X to regimen Y, and does it improve outcomes? It's usually compounding treatment and making it more toxic. But most patients, if you're looking at long-term survival and cure rates, are willing to accept a little bit more toxicity. And these two approaches are often contradictory. Again, when you're decreasing morbidity, you're usually de-escalating therapy. Improving survival, you're usually intensifying therapy. So what does that mean for head and neck cancer? So many of the studies in HPV positive head and neck cancer nowadays are looking at how can we decrease morbidity? How can we actually de-escalate therapy? So this was a study looking at radiation with or without cetuximab. So cetuximab is a monoclonal antibody against EGFR. None of these patients received chemotherapy. They were treated either with radiation alone or radiation with cetuximab, and you can see that the radiation with cetuximab arm was better by about 10% in terms of overall survival. Interestingly, though, when you look at the site of the primary tumor, if you separated these patients out, these 200-some patients, and separated them out by where was their site of tumor, when you look at the bottom there, the oropharynx was significantly better. Those patients did significantly better with the addition of cetuximab, much more so than the laryngeo or the hypopharyngeal patients. And so that has raised some questions about, could there be something about cetuximab in HPV-positive tumors, and is that where we should go? The thing to know about cetuximab concurrent with radiation versus chemotherapy concurrent with radiation is generally much less toxic. About 75% of people will get an acne-like rash. There's a small risk of an infusional reaction. But aside from that, it's very well tolerated. when you look at chemotherapy with radiation, the side effects are fairly substantial. And so in some people's mind, this is a de-escalation of therapy. It may or may not actually truly be a de-escalation in the sense of we don't know how that affects overall survival. These curves are similar to what you see with the addition of chemotherapy with radiation. But this has raised some questions about whether cetuximab could have a role in HPV-induced cancers by maintaining that excellent survival rates, but also decreasing morbidity of treatment. So there are a few cooperative group studies now looking at that. So ECOG actually has a study where patients are getting chemotherapy with cetuximab, and those who have a complete response to treatment then go on to get less radiation. So we know that a lot of the long-term effects of head and neck cancer and the long-term toxicity is associated with the radiation dose. And so can we somehow spare patients that additional radiation and spare them some of those long-term side effects? People who don't have a complete response will go on and get more standard radiation with cetuximab. The RTOG, which is the group we most commonly participate in, is actually looking at a study for P16 positive patients and randomizing them to chemotherapy with radiation or cetuximab with radiation, again, with a little bit of that knowledge about whether or not cetuximab could de-escalate therapy and also provide that same survival advantage. You know, this is a study I came across actually in the lay press. It was presented, and it was actually it's not even in print yet, I don't believe. But other ways people are looking at treating HPV cancers, aside from de-escalation of therapy, when you think about HPV-induced cancers, how else could we change our treatment or change things to improve survival and decrease morbidity? So E6 and E7, again, are constitutively expressed throughout the course, and E6 inactivates P53 by two mechanisms. It associates with the E6AP, which degrades P53, and then associates with P300, which blocks P53 activation. And so this study was actually looking at, CH1 is actually a unit of P300. And basically when you look at overexpressing that, you actually block P300's activity and allow P53 activation. And certainly when they introduced CH1, you saw increased P53 activity, acetylated P53 in those cell lines. In tumor volume in mice, again, when you look at the empty vector versus the CH1, statistically significant decreases in tumor volume. So it's interesting how, what about HPV lends itself to more interesting novel therapies. Immunotherapy. So people have looked at immunotherapy. We know that HPV, the immune system plays a very important role in controlling HPV infections and even in maintaining them. So HPV infections, even once the cancer has been initiated, in HIV patients do very poorly. HIV patients with anal cancer, with head and neck squamous cell carcinomas do worse than patients who are immunocompetent. And so there's something about the immune system, even once the tumor is there, that does control the outcomes. And so people have looked at immunotherapy targeting the E6 and E7 and other approaches there. Targeted therapy, of course, and then looking at modulators of drug resistance. So again, how do we improve cancer treatment? And when we look at improving cancer treatment, again, it's decreasing morbidity, improving survival, but finally, early detection and prevention. And that's really the unsung hero here, and we hope will, 20 to 30 years from now, see those curves trending down again. So the HPV vaccine, of course, is what I'm talking about, and originally approved in girls and then in 2009 for boys as well. It was expected to decrease the incidence of cervical cancer, and now I think most people expect it will also decrease the incidence of HPV-related head and neck cancers, particularly since HPV-16 is part of both the quadrivalent and bivalent vaccines. You would expect, since the vast majority of head and neck cancers are associated with HPV-16, that should come down fairly dramatically, hopefully in the next 20 to 30 years. We have no idea, to be honest, but you would expect that it would, and you would hope that it would. The problem is, this is actually just published in 2013, and this was data based on 2010. So this is about 3 to 4 years after the vaccine became available. And still, in most states, well less than 50%, maybe even less than a third of girls aged 13 to 17 are actually being vaccinated. And so that's part of the problem. It's taken some time to get this into the mainstream, and hopefully with time that will improve. There is Also, that feeling of even if you're not vaccinating everybody, there is some herd immunity. So if you can eliminate some of the virus, you're decreasing exposure and decreasing risk there. But that continues to be a problem. So in summary, HPV-positive head and neck cancers are increasing in incidence fairly exponentially. It is an epidemic. Regardless of the modality of treatment, survival for HPV-positive head and neck cancers is superior, and quite significantly so. To date, we don't really have any data to suggest we should change how we treat them, so most patients, unless they're on a clinical trial or on a protocol, are treated with chemotherapy and radiation just as they would if they were an HPV-negative cancer. It's unknown whether the HPV vaccine will decrease incidence, but it's reasonable to expect that it would. And again, less than a third of young girls in Kentucky who are in the age at which they should be vaccinated are actually being vaccinated as of just a few years ago, and so hopefully those numbers will improve with time. That's it. Thank you.
Thank you so much. Let me ask you a question. Your data suggests, particularly the ones that you presented where there's differences in outcome, that we're lumping all these head and neck cancers all together, and that location, but perhaps type of cancer, and whether they have EGF or not, is a big deal. What's known about how do we begin to distinguish one type of head cancer from another?
In terms of anatomical location?
Well, I think there are groups already in the United States. The Vanderbilt group is one that comes to mind, but not the only one, that has begun to consistently and reliably evaluate genes in a number of cancers, particularly lung cancer. So when you come back to see your patient, you have not only you have adenocarcinoma, but these are the genes, and this goes for this particular chemotherapy treatment. Are we there for head and neck cancer?
You know, we're not, and probably it probably lags behind other tumors. I think lags behind lung cancer and breast cancer in that regard. Probably because of the heterogeneity of head and neck cancer. Even within the HPV positive or HPV negative population, there are different risk factors. The anatomical location is different. They're treated differently. The mainstay of head and neck cancer historically, it's an exciting time for a medical oncologist in head and neck cancer because our role is becoming more important. Historically, it's been a surgeon's disease, it's been a radiation oncologist disease. And so a lot of the medical oncology in head and neck cancer, I think, is finally starting to catch up and realizing that systemic therapy is important, that patients are surviving their primary tumor and distant relapse and things are becoming more of an issue. So I think we're getting there. I think we're not quite where we are with other cancers.
I also was going to ask you about preventive therapy because you're taking away smoking, alcohol, sex, and even kissing. And I'm now thinking, okay, what else? Are there issues about dietary interventions? What is the role of obesity in this process? Antioxidants, all these things. Is there anything else that we should not be doing?
I think if there's anything else, it wouldn't have much to do if I took away eating as well. But it's not quite as well teased out as it is in some cancers. We know a lot of times obesity and a fatty diet are certainly risk factors for other types of cancer of the GI tract in particular. Whether that's as much of a role for the sort of upper aerodigestive tract, it's not totally clear. You would expect it probably would be, but that's not quite as teased out as it is in other more distal GI.
Questions? Yes, sir.
Rebecca, great review. What about screenings? Any use of screening for high-risk groups?
Yeah, so people have looked at that. It's difficult because who's high risk? So you have to sort of define who are your high risk patients and who are the patients who get oral HPV. They're us. So who's high risk? Who do you define? And so if you can identify who has the oral HPV-16 infections, which would require you to basically take oral samples, everyone out in the population, and then once you get those patients, the problem becomes where the cancers are in the oral pharynx is a very difficult place to locate or to get to if you are a primary care doctor. Sort of sampling the base of tongue is not really feasible in the office. So it's been logistically difficult, and it's been a problem of it's a fairly small number of patients and in a huge population of we don't know who is high risk. All of us are.
Actually, I like that question because in cancer we know, in lung cancer, the earlier we detect it, the more we can resect it.
Right.
And cure potentially. But here, resection is more of a problem. No? So what is the data for early detection and eradication?
So certainly the earlier the better. When you look at screening, there's certainly data when screening in HPV negative tumors in smoking and alcohol, and looking at people who are smokers and having regular screening. What's hard in HPV positive tumors, of course, is they have very small primaries. So when you're trying to catch a pre-malignant lesion, it's very difficult. But even when you're trying to catch it early, when you're trying to find it early, the problem is a lot of patients with HPV positive tumors are not symptomatic from their primary tumor. So it's hard to catch them early. Maybe they have a little bit of tonsillar fullness that they would never notice even in looking in the mirror, but they oftentimes present when they're already fairly locally advanced. It's actually unusual to have a stage 1 or 2 HPV positive tumor. Most of them are stage 3 or 4 simply because of that.
And that improvement has been dissociated from potential lead time bias?
Yes. So when you look at most of the studies that enroll HPV positive and HPV negative tumors who are stage 3 or 4, locally advanced nodal disease, consistently the HPV positive population has earlier stage T stage. They typically are T1 or T2 tumors. When you look at the HPV negative population in that same study who have stage 3 or stage 4, they're more likely to have T3 or T4 primary lesions.
Here and then there.
I want to kind of follow up on the prevention comment. You said who to test and what have you. Right now, with Gardasil vaccine, et cetera, they're targeting early adolescents, not infants, which perhaps is a good population. But then you potentially miss an opportunity for a lot of folks who are still negative adults. And you mentioned how do you screen everyone? Well, if you screened everyone and they were negative, then they would be good potentially vaccine candidates to prevent cancer. And then if they were positive,
right,
you have a group that might someday have a screening protocol. Do you see any movement from the vaccine direction to expand who is offered that vaccine?
Possibly. The hard part about that is that a lot of HPV infections are cleared. And so just because they don't actually have the infection doesn't mean they haven't been exposed to it and are already quote-unquote immune to it. So that's the hard part in testing. What you're testing and what you're seeing is probably a small proportion of what that patient has actually been exposed to, and so whether the vaccine would be helpful in that patient population or not, it's not clear.
Christine, and then this
It's
gentleman.
also a vaccine question. With tenfold increased incidence in men, when are they going to go ahead and expand and offer this to guys?
Well, they do. It's just it's not even been widely accepted in girls, and I think it's been even less in boys. It is FDA approved now in adolescent boys. I think I didn't pull up incidence of how many people are being vaccinated, but the numbers are even smaller than it is in girls. So it's there, it's out there. I think that a lot of the publicity about the Gardasil vaccine is cervical cancer, and so people don't think about it in boys unless your pediatrician is mentioning to you, and hopefully more and more are. I think boys are not being vaccinated routinely.
Yes, sir.
With respect to detection, classic oropharyngeal lesions, erythroplasia, mixed erythroplasia, anything known about early or precursor HPV lesions with respect to early detection?
In terms of whether they present the same way in terms of leukoplakia, they certainly can. Not quite as they are. When you look at them under the microscope, they tend to be much more poorly differentiated. They tend to progress much more quickly. So I think they have less of that indolent leukoplakia sort of not lead time, but time between when there's an abnormality and when they actually present with advanced disease. But they certainly can. I think the process is much quicker.
Any other questions? If not, thank you very much. Enjoy your day. Very nice. I learned quite a bit.